Welcome back. Happy to reconvene our ACIP meeting for the last session of the day. We're looking forward to hearing from our HPV vaccine work group. And, actually, I take it back. We're looking forward to hearing updates about HPV vaccines from our colleagues at CDC. And I believe we have 3 presentations today. The first by Dr. Shannon Stokely on the status of HPV vaccine coverage in the US and effects of the COVID-19 pandemic. The second from Dr. Julia Gargano, and the third presentation from Dr. Lori Markowitz. So Dr. Shannon Stokely, please go ahead. Oh, Dr. Markowitz, are you going first?
Can you hear me, first of all?
Yes.
Okay.
Thank you.
I'm going to give a brief introduction to the session because we do not have a work group, as you mentioned, so I'm going to do the introduction. Okay, so just briefly, the purpose of this session is to provide an overview of evidence on one-dose vaccination for ACIP and to summarize updated recommendations of WHO's Strategic Advisory Group of Experts on Immunization that were made in April 2022. And today we'll also have a brief update on HPV vaccination coverage in the US and impact of the vaccination program. And because the last presentation to ACIP on HPV vaccine was in 2009, we're going to start with a very short introduction. All currently available vaccines are virus-like particle vaccines, and these VLPs self-assemble spontaneously from 72 pentamers of the L1 major capsid protein. And because they're produced from a single virion protein, they're non-infectious and non-oncogenic. And these VLPs are morphologically similar to authentic virus and induce high levels of neutralizing antibodies.
Dr. Markowitz, don't forget to say next slide.
There are 3 vaccines licensed in the United States. They differ in the number of types targeted, the adjuvant used, and the protein expression system. All 3 target 16-18 HPV types that cause most HPV attributable cancers. And the quadrivalent and 9-valent vaccines also target 6 and 11 types that cause most anogenital warts. The 9-valent vaccine targets 5 additional cancer-causing types. And all of these vaccines have been found to have very high efficacy against vaccine targeted types. The quadrivalent vaccine was the first licensed in the US in 2006, followed by bivalent in 2009 and 9-valent in 2014. And before 2015, almost all vaccine used in the United States was the quadrivalent vaccine. Next slide. And after the end of 2016, only the 9-valent has been available in the US, although this is all the vaccines are available in other countries. Next slide. In the US, HPV vaccination was recommended in 2006 for females, and at that time, HPV vaccine was only licensed in females, and routine vaccination was recommended at age 11, 12, and the series can be started at age 9. And catch-up was recommended through age 26. In 2011, routine vaccination of males at age 11 to 12 was recommended, with catch-up through age 21. Vaccination was first recommended as a 3-dose schedule, and in 2016, a 2-dose schedule was recommended for those starting vaccination before age 15. And in 2019, catch-up vaccination was harmonized through age 26 for everyone, and also after expansion of the age indication through age 45, a recommendation for shared clinical decision-making was made for persons aged 27 through 45. Next slide. And then these are our current recommendations for HPV vaccination, which include routine, catch-up, and shared clinical decision-making. The next slide. And just a reminder that the number of doses recommended depends on the age of the series is initiated, with 2 doses recommended for those starting the series before age 15. Next slide. So with that brief intro, I will we'll move to the presentations. The first is on national and state level vaccination coverage by Dr. Shannon Stokely, followed by a presentation on impact of the vaccination program on HPV-associated outcomes by Dr. Julia Gargano, and then I'll provide the presentation on one-dose vaccination.
Thank you. If we could pull up Dr. Stokely's slides, that would be terrific. Please go ahead.
Thank you, and good afternoon. If you can move to the next slide. So today I'll be providing an overview of adolescent vaccination coverage levels and also discuss the impact of the COVID-19 pandemic on routine vaccination, and then talk a little bit about our efforts to increase routine vaccination. Next slide. Next slide. So we monitor adolescent vaccination coverage through the National Immunization Survey Team, and this is a cell phone-based survey of parents of adolescents aged 13 to 17 years. And when we have consent from the parent, vaccination histories of the adolescents are obtained from the medical provider, and therefore our estimates are based on medical records and not parental recall. And this slide shows the trend of vaccination coverage from 2006 through 2020, which is the most recent year of data available to us. And so Tdap vaccination is shown in red, meningococcal vaccination is shown in blue, and the first dose of HPV is shown in orange, and up to date for the HPV series is shown in green. And so nationally, vaccination coverage for Tdap and meningococcal vaccination is high at about 90%. And this is much higher than coverage observed for HPV. Coverage for the first dose of HPV vaccine is 75%, and coverage for the HPV series is 59%. And although coverage for HPV is lower than other routinely recommended vaccines, it does continue to increase each year, even in 2020. Next slide. Shown here is first dose HPV vaccination coverage by state, and you'll see there is a wide variation in coverage across the country, ranging from 55% in Mississippi to 93% in Rhode Island. And coverage is typically lower in the Southeast. Next slide. And shown here is coverage for the HPV series. Again, coverage ranges from 32% in Mississippi to 83% in Rhode Island, and a similar pattern emerges with lower coverage in the Southeast. Next slide. Since the HPV vaccine has been licensed and introduced, we have observed an interesting pattern in vaccination coverage by race ethnicity. And consistently over time, vaccination coverage has been higher for Hispanic and non-Hispanic Black adolescents compared to non-Hispanic white adolescents. And it's not clear what may be driving these differences, but the pattern holds whether we're evaluating initiation of a series or series completion. Next slide. And we also see differences in vaccination coverage by urbanicity. And vaccination coverage has consistently been lower for adolescents living in rural areas, usually around 12 percentage points, though this difference appears to be narrowing in the most recent years of data. But what we do see is that vaccination coverage for adolescents living in rural areas does increase at the same rate as those living in urban areas. It's just that it's much lower than the urban population. Next slide. So in summary, we continue to see high vaccination coverage for Tdap and meningococcal vaccines. HPV vaccination is lower, but it does continue to increase. And we continue to see differences in coverage by race ethnicity and by MSA status or urbanicity. Next slide. Now I want to spend a few minutes discussing the impact of the COVID-19 pandemic on adolescent vaccination. And I know the past 2.5 years have been difficult on many fronts, and routine vaccination is no different. And we know there were disruptions in healthcare services in 2020, and some of those disruptions may continue. Next slide. So when we first saw the results of the NIS team for 2020, we were a little surprised that we didn't see a drop in coverage. But as we looked at the data, we realized that the 2020 survey really was not able to assess the impact of the pandemic because most of the teams included in the survey had started the vaccination series prior to the pandemic. So remember, the survey includes teens ages 13 to 17 years, and the survey measures vaccination received at any point in their life. And so most of these teens had actually started the HPV series before 2020. So we will need additional years of data to truly assess the impact of the pandemic. And as a side note, we are just now receiving the data from 2021 survey, and that should be available later this year. Next slide. So although we don't have survey data, another way we can evaluate the impact of the pandemic on routine vaccination is by monitoring our vaccine orders for the Vaccines for Children program, also known as VFC. And the VFC program provides vaccines at no cost for children who would otherwise not be able to afford vaccination. And in the US, about 50% of children receive their vaccines through the VFC program. And we monitor vaccine orders by fiscal year. And for us, the fiscal year runs from October 1st through September 30th. And this figure compares VFC provider orders for the HPV vaccine for fiscal years 2019 through 2022. And just to orient you to the slide, the purple portion of the bar represents orders from October through May, and this allows us to compare the same time period across years, since the current fiscal year, 2022, is not yet complete. And then the hash mark portion of the bar represents orders from June through September, and the total height of the bar represents the total orders for the year. And so using fiscal year 2019 as our baseline, we see that total orders decreased about 24% in fiscal year 2020. And in fiscal year 2021, there was improvement in total orders, but they were still about 9% lower than 2019. And then looking at the year-to-date orders for 2022, we see that orders are about 10% lower than the same time period in 2019. Next slide. Another way we can evaluate the impact of the pandemic is looking at data from Immunization Information Systems, also called IIS. We receive IIS data from 13 jurisdictions and evaluated HPV vaccination coverage by age from 2018 through 2021. And so this is data that we just recently received. And shown here is coverage for one or more doses of HPV vaccine. And vaccination coverage increased slightly in 2020 and 2021 for adolescents 13 years of age and older. Where we see an impact is with the 11 to 12-year-old age group. And so compared to 2018, coverage decreased 3 percentage points in 2020, and coverage continued to decrease in 2021. Next slide. And a similar pattern emerges when we look at coverage for 2 or more doses of HPV vaccine. And we have slight increases each year for the older adolescent age groups and a slight decline for the 11 to 12-year-old age group. Next slide. So in summary, vaccine orders and vaccine administration have decreased since the start of the pandemic, leaving some children unprotected from vaccine-preventable diseases. From surveys we've done, we know parental concerns about potential exposure to COVID-19 may be contributing to declines for making well child visits when vaccines are usually administered. And efforts are needed to help children get caught up on vaccines they may have missed during the pandemic. Next slide. So over the coming months, we will need a multifaceted approach from all stakeholders to ensure children get back on track with the routine vaccinations. And CDC has launched the Let's Play Catch-Up campaign to help with this effort. And the links shown on the slide can take you to materials that we have available to help promote routine vaccination. And that includes a toolkit for providers, social media message, and other materials to help promote vaccination. Next slide. But some activities that healthcare systems providers can do now include encouraging members to identify and follow up with families who may have missed vaccination so that they can schedule an appointment. Also implement clinician prompts to remember to review a patient's vaccination status during an office visit so they can recommend and offer vaccines that may be due or overdue. Communicate directly to families about the importance of well child visits and routine vaccinations. And finally, let families know about precautions that are in place so that they know there'll be a series of services when they come in person. Next slide. So I just want to acknowledge the work of my colleagues that helped put together this presentation. And I'm happy to take questions now or later in the session. I'm not sure how we're doing that this time, but I'm happy to take questions.
Thank you, Dr. Stokely. This presentation is now open for questions. Dr. Goldman.
Thank you. Just a brief comment. Great presentation, and I really want to impress upon the internal medicine community as well when you talk about catching up for vaccines. I give all adult vaccines in my office, and I routinely, of course, ask my 18, 19-year-olds about if they've received a Gardasil vaccine. So I think it's important that in the outreach, we also include the internal medicine community as well, because that is still an opportunity to catch those who haven't been vaccinated for whatever reason in pediatrics. But thank you for bringing this issue up, and I think it's really important to engage all stakeholders. Thank you.
Thank you. Dr. Daly?
Yeah, thanks, Dr. Stokely, so much. Matt Daly here. I found the ordering, sobering, because you were talking millions, and I think that means millions of individuals in this age group who aren't protected. Is the scope of that consistent with what you're seeing from IIS? In other words, do the sort of numbers match up that we have an estimate about how many folks have missed their opportunity for HPV vaccination if you sort of triangulate those two data points? Thank you.
Yeah, thanks for that question. So we're looking more closely at the data that we did receive from the 13 IIS jurisdictions. When I looked at their ordering data and looked at their coverage data, it's not always a one-to-one correlation. There were some jurisdictions that had lower orders. However, their coverage did not show that decrease, or did not have as large of a decrease as some other jurisdictions where the ordering impact was not as large. So we need to do further analysis to really look at the correlation. And some things that might have been happening with orders, what we're not sure of is if we don't know how much stock providers had on hand at the beginning of the pandemic. And so maybe, they didn't need to order as much as fewer kids were coming in for a little bit. There's a lot more that we need to do to truly understand that relationship between the orders and coverage.
Okay, thank you.
Dr. Paley?
I want to say thank you for a great presentation. And on your earlier slide was something that I think we need to highlight for everybody, and that the 2 doses works great if you're immunocompetent and you begin less than 15 years of age. But I think we need to reiterate, as we try to protect our immunocompromised, that they always need 3 doses of vaccine. And then there is a huge advantage of starting at a younger age. Thank you.
Thank you. Thank you. Are there any additional questions? Well, why don't we move on to the next section, which is Dr. Julia Gargano from CDC will discuss the impact of the US HPV vaccination program on HPV-associated outcomes. Dr. Gargano.
Good afternoon. First, is my sound okay?
Yes, we can hear you loud and clear.
Great. Okay, next slide, please. Monitoring impact of the HPV vaccination program in the United States has been done using a variety of early, intermediate, and late outcomes. Next. Today, I'm going to review some of the most recent data on HPV prevalence in females, juvenile onset recurrent respiratory papillomatosis, or JORP, cervical precancers, and cervical cancers. Next slide. CDC has collected genital specimens using population-based surveys through the National Health and Nutrition Examination Surveys in Haines since 2003 for females and since 2013 for males. HPV typing results are linked to demographic and behavioral data, as well as self or parent-reported HPV vaccination history. Next. In the first 4 years after the vaccination program began, quadrivalent vaccine type HPV prevalence was 56% lower in females aged 14 to 19 years than in the pre-vaccine era. Next. By 2015 to 2018, quadrivalent vaccine type prevalence was 88% lower than the pre-vaccine era among 14 to 24-year-old females, and 81% lower, that was among 14 to 19-year-old females, and 81% lower among 20 to 24-year-old females. No significant decrease was seen in the older age groups, and non-vaccine type prevalence did not change significantly, suggesting that the declines in vaccine type prevalence were not due to lower HPV exposure. Next slide. Vaccine impact was also estimated among vaccinated and unvaccinated sexually experienced females. In the 14 to 19-year age group, quadrivalent vaccine type prevalence was 97% lower among vaccinated females in 2015 through 2018 compared to the pre-vaccine era, and 87% lower among unvaccinated females. In 20 to 24-year-olds, prevalence was 86% lower in the vaccinated group and 65% lower in the unvaccinated group. These data show strong direct impact of vaccination as well as robust evidence of herd protection. Next. NHANES data were also used to evaluate vaccine impact by race and ethnicity, comparing quadrivalent vaccine type prevalence in 2013 through 2016 to the pre-vaccine era. In 14 to 19-year-olds, declines in vaccine type prevalence were significant for non-Hispanic white, non-Hispanic Black, and Mexican American females. Next slide. Okay, so now moving on to a very different outcome, juvenile onset recurrent respiratory papillomatosis, or JORP, which is almost entirely caused by HPV type 6 and 11, mainly from vertical transmission at the time of delivery. This figure summarizes findings about the numbers of JORP case patients by birth year, the purple bars, and estimated incidence based on state-level denominator data in the yellow line. In 2008 to 2009, declines in U.S. JORP incidence had begun to occur. Those declines continued in every subsequent set of years. These data suggest that the number of children with JORP has declined significantly in the years following HPV vaccine introduction for adolescents and young women in the United States, and that these declines are most likely due to HPV vaccination. Next. Data from population-based surveillance, administrative claims, and cancer registries have been used to evaluate vaccine impact on incidence of cervical precancers in the United States. Monitoring impact on precancers is challenging due to changes in cervical cancer screening recommendations during this time period, including a major change in 2012. Cervical precancers are only detected by screening, so it is preferable to use the number of screened women as the denominator in incidence calculations. All approaches have shown decreases in cervical precancers in young women consistent with vaccine impact. Next. These data are from HPV Impact, which is a 5-site population-based monitoring project that is collecting data on both precancers and screening. Rates of precancers, here abbreviated CIN2+, among screened women decreased between 2008 and 2015 among both 18 to 20-year-olds, the solid pink line, and among 21 to 24-year-olds, the solid red line. Rates increased in screened women in older age groups. The trend in 25 to 29-year-olds is shown by the light blue dashed line. Similar increases in this age group have been found in other studies and are thought to be attributable to longer screening intervals and/or increased sensitivity of new screening tests. Next slide. In HPV Impact, HPV typing is performed on tissues from precancerous lesions. In this analysis, typing data were used to estimate the number of CIN2+ cases caused by HPV 16 and 18, the high-risk types targeted by the quadrivalent vaccine. The estimated numbers of vaccine type CIN2+ declined significantly, whereas the estimated numbers of CIN2+ not caused by HPV 16 and 18 remained approximately constant, showing that the vaccination program is the most likely cause of the observed declines in CIN2+ incidence. Next slide. Finally, trends in invasive cervical cancer have been evaluated using data from United States Cancer Statistics, which is a database of cancer registry data that covers 97.8% of the US population. Here, I'm showing data for 21 to 24-year-olds. Incidence of invasive squamous cell carcinoma of the cervix has been in decline for many years due to the cervical cancer screening program. This analysis showed that, starting in 2012, the slope of the trend became more pronounced. These data do not account for changes in cervical cancer screening that started in 2012, so it is difficult to know how much HPV vaccination contributed to this trend. Of note, there was also an inflection point in 15 to 20-year-olds in 2011 to 2012, which is less likely to have been influenced by screening. Next. In summary, data from impact monitoring projects has shown that prevalence of the quadrivalent HPV vaccine types has declined markedly, both among vaccinated and unvaccinated young females in the United States. The declines in high-risk HPV type 16 and 18 have translated into declines in cervical precancer incidence in young women. The declines in HPV type 6 and 11 have resulted in a reduced incidence of JORP. Early impact on invasive cancer in young women might be occurring. The trends I've shown today go through 2018 at the latest. Monitoring will continue to assess the impact of vaccination in females and males and the impact of the 9-valent vaccine. Next. I would like to acknowledge the individuals and groups whose data, analyses, or feedback contributed to this presentation. Thank you, and I'll be happy to take questions.
Thank you. This presentation is now open for questions. I don't see any hands raised, but I'll just comment that it's really wonderful to see this data and kind of get that closed loop feedback about the impact of the vaccination program. So thank you very much for putting that together, and it's actually really impressive. I don't see any additional hands raised. Are there any comments or questions for us? Okay, well, why don't we move on to the last presentation of the day, and Dr. Gargano, maybe you can hang on in case there are questions that come up after Dr. Markowitz.
I'll be here. Thank you for the opportunity to present.
Thank you. Dr. Markowitz, you will be presenting on the recent data on Windows HPV vaccination. So please go.
Okay, good afternoon. Next slide. The main objectives of this presentation are really just to update ACIP and data regarding one-dose vaccination and to review the recently revised recommendations of WHO's Strategic Advisory Group of Experts on Immunization. And it's really not meant to be a comprehensive review nor an assessment of the data. It's really an information-only update, and I do want to mention that currently there's no active ACIP HPV vaccines work group. Next slide. So the outline of what I'm going to be talking about is background. I'm going to first provide information on data that was required for initial licensure of HPV vaccines in 2006 and the change to a 2-dose schedule in 2016. And then I will go on to summarize the 1-dose vaccination evidence and then end with a summary of the SAGE recommendations from the April 2022 meeting. Next slide. So efficacy and immunogenicity data that were submitted to FDA for initial licensure of HPV vaccines were from trials conducted with a 3-dose schedule, with the second and third doses administered 1 to 2 and 6 months after the first dose. And these data were from randomized controlled efficacy trials in 15 to 26-year-olds, and the trial endpoints were cervical precancer lesions. And efficacy against vaccine type endpoints was over 96% in per protocol analyses, which included women who were naive to the vaccine types, and seroconversion 1 month after the last dose was close to 100%. There were also immunobridging trials in 9 to 15-year-olds, as it was not feasible to conduct efficacy studies in this age group. And licensure in 9 to 15-year-olds was based on non-inferior antibody response compared to women in the age group of the efficacy trials. Next slide. Interest in a 2-dose schedule was stimulated by a post hoc analysis of a 3-dose randomized controlled trial in which not all individuals completed the schedule. And in these analyses, efficacy against instant, persistent 16-18 infection was similar after 3, 2, and 1 doses. And following publication of those data, immunobridging trials were conducted to evaluate 2 doses given in an interval of 6 or 12 months in 9 to 14-year-olds compared with 3 doses in women in the age of the efficacy trial. And seroconversion and GMTs were non-inferior in the 2-dose groups compared with those in the 3-dose group. Next slide. And this slide just shows some of the results from the 9-valent immunobridging trial. GMTs 1 month after the last dose against the 9-valent types were consistently higher in girls who received 2 doses at 0 to 6 months, shown in blue, compared with young women who received 3 doses in yellow. And there were similar findings for boys and for girls and boys who received vaccine doses at 0 and 12 months. Next slide. Here are the immunobridging data from a quadrivalent vaccine trial. In this trial, there were 3 groups, 2 doses in 9 to 13-year-olds in black, 3 doses in 9 to 13-year-olds in red, and 3 doses in 16 to 26-year-olds in green. And I'm showing this because it demonstrates titers through 36 months. And you can see not only the non-inferiority of the antibody titers in the 2-dose compared to the 3-dose groups, but also that the antibody kinetics with a decline 1 month after the last dose and then a plateau in stable antibodies was similar regardless of the number of doses. Next slide. The 9-valent manufacturer submitted a supplemental biologics license application for a 2-dose series for 9 to 14-year-olds in 2016. FDA approved this application, and ACIP recommended a 2-dose series for persons starting vaccination at age 9 to 14 years. And 3 doses are still recommended for persons with immunocompromising conditions and for persons starting the series at older ages. Next slide. Now moving on to evidence for 1-dose vaccination. Next slide. The same studies that stimulated interest in 2-dose schedules led to interest in 1-dose vaccination. However, immunobridging studies were not possible because 1 dose results in lower antibody titers than 2 or 3. The basis of protection after vaccination is thought to be neutralizing antibody. However, there is no minimum antibody threshold for protection. Very low levels of antibody are thought to be protective against HPV, levels lower than those detectable by available assays, and efficacy trials were felt to be needed to evaluate 1-dose vaccination. Next slide. This slide shows the design for SCUDO, an efficacy trial being conducted by the US National Cancer Institute. This large randomized double-blind trial is investigating the non-inferiority of 1 compared with 2 doses of bivalent and quadrivalent vaccines for prevention of 16-18 infections and to evaluate 1 dose compared to those unvaccinated. Bivalent and 9-valent vaccines are being evaluated separately among 12 to 16-year-old girls in Costa Rica who are being followed for up to 5 years. And the study also includes surveys of unvaccinated women to allow estimates of vaccine efficacy by comparing persistent infection in these women with the vaccinated trial participants. No interim analysis is planned in this ongoing trial, and results should be available in 2024. Next slide. Meanwhile, interest in 1-dose vaccination increased for several reasons. A global HPV vaccine supply and demand imbalance was recognized, and this limited HPV vaccine introductions in some countries. While more countries have introduced vaccine, global vaccination coverage continues to be low. In 2020, it was estimated that only 13% of girls worldwide were fully vaccinated by age 15. And there continued to be challenges implementing HPV vaccination programs. Additional studies were initiated to evaluate 1-dose vaccination, and studies that had provided the initial data on 1 dose had further follow-up data. Next slide. I'm going to briefly review these 5 trials that were considered by SAGE. The first 2 trials, the Costa Rica vaccine trial and the India IARC trial. In these studies, participants were not randomized to a one-dose group, but one-dose data from post-hoc analyses. Following that, I'll summarize data from a trial in Kenya and a trial in Tanzania. In both of these trials, participants were randomized to a one-dose group, and then I'll review data from an impact study in Thailand. Next slide. The Costa Rica vaccine trial was the trial that originally raised interest in 2- and 1-dose schedules, and this now has data through 11 years after vaccination. Again, the data are from a post-hoc analysis of a randomized controlled trial, and a control group of unvaccinated women was recruited after the blinded phase to allow for continued efficacy determination. And as shown, for prevention of prevalent efficacy for prevention of prevalent HPV-16 18 infection was similar in all dose groups. Next slide. Serum antibody was also measured through 11 years of follow-up in this study, and this slide shows HPV-16 antibody. The purple is the 3-dose group, the red the 2-dose group, and the blue 1-dose group. While the antibody titers are lower in the 1-dose group than the 2 or 3, titers are relatively stable in all dose groups through 11 years after vaccination and at least 10-fold higher than in the unvaccinated group shown in black at the bottom of the figure. Next slide. The India IARC trial was designed as a cluster randomized trial to compare 2 versus 3 doses of quadrivalent vaccine. It was initiated in 2009. Less than a year after vaccination, HPV vaccinations were stopped by the Indian government due to issues unrelated to this trial. However, much of the enrollment, randomization, and initial vaccination had occurred, although not all participants could complete the schedule to which they were randomized. The study has been analyzed as an observational cohort with 4 different vaccination schedules, including a 1-dose group. Next slide. Participants were followed yearly, and data are now available through 10 years after vaccination. Cervical specimens were collected 18 months after marriage or 6 months after first childbirth to assess HPV infection. And again, unvaccinated women were age matched to the married vaccinated participants and recruited as controls. Vaccine efficacy against persistent 16-18 infection was analyzed, adjusting for an imbalance in the distribution of potential confounders. And efficacy against persistent 16-18 infection was similar in all dose groups. Next slide. Now moving on to the more recently conducted trials in which participants were randomized to a 1-dose group. The KEMSHI trial is a randomized double-blind controlled trial conducted in Kenya, published last year. The young women, aged 15 to 20 years, were randomized to 1 dose of 9-valent, 1 dose of bivalent, or 1 dose of meningococcal vaccine. 1,458 women were evaluated for efficacy at month 18 in the modified intent to treat cohort, who comprised participants who tested HPV antibody negative at enrollment and DNA negative at enrollment in month 3. There were 38 incident persistent infections detected, 1 each among participants in the bivalent and 9-valent groups, and 36 in the meningococcal vaccine group. The vaccine efficacy was 97.5% for both HPV vaccines. Next slide. And this is the efficacy data against all 7 oncogenic types targeted by the 9-valent vaccine. There were 29 infections in the control group and 4 in the 9-valent group for an efficacy of 88.9%. Next slide. DORIS is a randomized trial of 1, 2, and 3 doses of bivalent or 9-valent vaccine. The study included 930 Tanzanian girls aged 9 through 14. The objectives were to demonstrate non-inferiority of HPV-16-18 antibody after 1 dose compared with 2 or 3 doses of the same vaccine at month 24, and to demonstrate non-inferiority of HPV-16-18 geometric mean concentrations comparing 1 dose in this study with 1 dose in studies that evaluate efficacy. Next slide. These are the seroconversion rates for HPV 16 and 18 after bivalent vaccine in the 1, 2, and 3 dose groups. Next slide. And in blue are the seroconversion rates for the 9-valent vaccine in the 1, 2, and 3 dose groups. For HPV 16, non-inferiority criteria were met for 1 dose compared to 2 or 3 for both vaccines. And for HPV 18, seropositivity was greater than 97.8% in all dose groups, but the strict non-inferiority criteria were not met for 1 compared with 2 or 3 doses. Next slide. And here are the geometric mean concentrations for HPV 16 on the left and HPV 18 on the right following 9-valent vaccination. 2 and 3 dose geometric mean concentrations in green and red decline after a peak of 1 month, and the levels plateau and were similar at all time points, so the lines are barely distinguishable. The geometric mean concentrations for 1 dose in blue are lower than for 2 or 3. However, there's a stable plateau, as has been seen in other HPV vaccine studies. Next slide. And this study also conducted a variety of other evaluations, and I want to mention that they looked at avidity, which is a measure of the strength of binding of antibody to antigen, and this was similar regardless of number of doses received or the vaccine. And the immunobridging analyses showed that seropositivity and the GMCs were non-inferior in the 1-dose groups in this study, compared with those in 1-dose groups in the trials where efficacy was observed. Next slide. And finally, the Thailand impact study is an observational study of 1 dose and 2 doses of bivalent vaccine given to grade 8 girls in 2 similar provinces in Thailand. The primary objectives are to demonstrate HPV vaccine effectiveness of 1 dose and 2 doses at year 2 and 4 post-vaccination. Effectiveness was measured by comparing vaccine type prevalence in year 2 and 4 versus unvaccinated same grade girls in a baseline survey. And there will also be an evaluation to determine if HPV vaccine effectiveness of 1 dose is non-inferior to 2 doses, and this will be done at year 4. Next slide. The results for year 2 are available and found that crude vaccine effectiveness against HPV 16-18 was 83.3% in the 1-dose province and 93.6% in the 2-dose province. Now, of note, there were some differences between the provinces, with more girls in the 1-dose province being sexually active at baseline. And in both provinces, there were differences in risk behavior in the year 2 survey compared with the baseline survey. And there were several methods used to adjust for exposure risk, and none of these resulted in important changes in the effectiveness estimates. Next slide. I'm not going to review the modeling data, but I do want to mention that extensive modeling has been conducted to evaluate the potential impact of 1-dose vaccination under assumptions that efficacy and duration are less than for 2 doses, although most of the clinical studies haven't shown this. And some of the modeling findings are summarized here. Compared to no vaccination, 1-dose vaccination yields substantial health benefits and is good value for money, even if efficacy is lower and duration of protection shorter than with 2 doses. And impact and cost effectiveness of adding a 2nd dose is driven by duration of protection and possibly the ability to achieve higher coverage or expand catch-up with 1 versus 2. And the projected impact and cost effectiveness of 1 versus 2 doses using a comparative modeling approach has been conducted by 3 modeling groups with extensive experience with HPV vaccine modeling. Next slide. WHO's Strategic Advisory Group of Experts on Immunization reviewed these and other data, and in April of this year made revised recommendations which were published last week. In this report, they state that on the basis of recent data on efficacy and effectiveness, SAGE endorsed the optimization of vaccine schedules. For 9 to 14-year-olds, national immunization programs can use either a single dose or a 2-dose vaccination schedule with an interval between doses at least 6 months. This off-label option for routine and multi-age cohort catch-up vaccination is recommended from a public health perspective on the basis of providing comparable levels of individual protection while being more cost-effective and efficient providing more program flexibility and enabling expansion of the multi-age cohorts targeted. Next slide. This slide shows 2017 WHO recommendations, which are still considered the current recommendations until publication of a revised position statement, and the 2022 SAGE recommendations. The primary group recommended for vaccination programs is unchanged, girls 9 through 14 years. SAGE recommended a 1 or 2 dose schedule for this group, and the 2017 recommendation is for a 2-dose schedule. SAGE also recommended that a 1 or 2 dose schedule can be used for women aged 15 to 20, and the 2017 recommendation is for a 3-dose schedule. And SAGE recommended that a 2-dose schedule can be used for persons aged 21 and older. 2017 recommendation is for a 3-dose schedule in this age group. And for immunocompromised, SAGE recommends at least 2 and ideally 3 doses be used. And the recommendations for number of doses for boys and men is the same as stated here, although SAGE recognized there are less data in males. Next slide. There are at least 3 additional studies, and there are more, I've just listed 3 here, that will provide additional data on single-dose vaccination. The first is an effectiveness evaluation being conducted in South Africa, and the last 2 are randomized trials, one an immunogenicity study being conducted in the Gambia, and the other is the large Escudo National Cancer Institute trial, which I mentioned earlier, being conducted in Costa Rica. Next slide. In summary, HPV vaccines were first studied and licensed in a 3-dose schedule in persons aged 9 through 26, and later in a 2-dose schedule in persons aged 9 through 14. There are now data on 1-dose vaccination, including efficacy data from a randomized controlled trial with 18-month follow-up. Long-term follow-up from other studies suggests good duration of protection with 1 dose. SAGE recommends 1 or 2 doses in the primary target age group, and WHO will consider and revise recommendations later this year. There is no regulatory approval for 1-dose vaccination in any age group or for 2-dose vaccination in any age group older than 14 years. The HPV team in the Division of Viral Diseases will continue to provide updates on these data and discuss with ACIP as requested, and to collaborate with and provide assistance to international partners. Next slide. Thank you.
Thank you for that update, Dr. Markowitz. This presentation is now open for questions, or the entire session can be open for questions, actually. Dr. Daly?
Yeah, thanks, Dr. Markowitz, for that presentation. Could we go to slide 15, I think it was? And I'm just trying to understand what I'm seeing here. So my crude understanding of sort of antibody titers is that they would typically decline over time at some rate. And the reason I'm asking this is in the context of all this other vaccine work that the ACIP does, including HPV, or excuse me, including COVID vaccination. So is there something different about the vaccine being viral-like particles, or something else about the disease, HPV, or something else that explains why there's not a declining antibody titer over time? Thank you.
Well, there's been a lot of discussion about this, and if you can go to, I do have a slide on this. I think it's slide 37. You can pull that up. There's been a lot of discussion, and I've just summarized some data, which is from a talk that Professor Stanley from Cambridge recently gave. And the feeling right now is it's both the VLP size and the geometry of the VLPs that really makes it so highly efficacious and immunogenic. The size is really optimal for entry into the lymphatics and transport to the B cell follicles. And this particle size is readily taken up by dendritic cells. And there's also been a lot of focus on the VLPs because this is a multivalent protein antigen with 360 copies of the L1 proteins that are assembled in this very dense repetitive array. And that's really felt to be very important for the immunogenicity of this vaccine. I've listed some other items on here. It is fascinating, and I think that obviously if ACIP is interested, we could arrange a session for discussion of why the current thinking about why this vaccine is so highly immunogenic and effective.
That's great. Thanks. Dr. Lee, can I ask a follow-up question then?
Of course.
So Dr. Markowitz, is the size of the VLPs related to the size of the virus? You know what I mean? In terms of the outer membrane of a HPV virus, or is it independent of that? It's just a really efficient way to present antigen to your immune system, and it doesn't relate to the size of the virus that it's trying to mimic, essentially.
Well, I think it is related to that because the VLP is like a authentic virus. It looks like an HPV virus, so it's definitely related to that.
Okay, it is also a really efficient way to present the antigenic protein. It sounds like so. Okay, thank you.
Thank you, Ms. Bata.
I'm just kind of ruminating. I remember the presentations in 2006 and beyond. I know this ages me, but thinking that the long-term outcomes were so far away, and here we are getting long-term outcomes, which are incredibly encouraging, and yet we still have many adolescents missing that opportunity for protection. And then I did have a question, and it took me a while to figure out what it was, and this is related to Dr. Gargano's presentation. When she was talking about prevalence of vaccine type HPV in 14 to 9-year-old females in 2013 to 2016 compared to pre-vaccination, and the one by race and ethnicity, and I think that's slide 8. In non-Hispanic Black, there was a 74% lower prevalence compared to 86 in non-white, and I was wondering why was that not lower if the vaccination rates were higher? Is it because there are some HPV types that just aren't being covered with the vaccine?
So I think it's not related to the types because this is really just looking at the vaccine targeted types and the prevalence of those types. It may, I can't, I don't have data to give a definitive answer on why the percent decrease is a bit lower in that particular group. It may have to do with a discrepancy in the age at vaccination and age at onset of sexual activity that is not captured in the data.
Thank you.
And Dr. Markowitz may have some other thoughts about that as well.
I think you gave a good explanation, Julia.
Thank you. Dr. Sanchez?
Yes, hi. Thank you for the presentations. I think it's really remarkable how effective this vaccine has been. And, even seeing the cases as a neonatologist of the juvenile respiratory papillomatosis decreasing so much it's been really encouraging as well. I guess my comment, I'm a little hesitant to just say, and I don't know where this is in terms of recommending a one-dose schedule. I'm a little hesitant knowing the progress that we've made, even though many are still unvaccinated, but among those who are vaccinated, the progress we've made in, and I don't know, the Thailand study is a little bit concerning. I think I would want more long-term information. I think the SAGE recommendations, I don't think we can make a recommendation that you can give 1 or 2 doses. I think we have to be certain of one or the other. be almost like a natural history of just one dose. So I think we have to be, and again, I'm not sure where you're at in terms of formulating the recommendations, but I personally think that we need a little bit more follow-up data from these randomized studies. And we really should, at one point, then say whether 1 or 2 is recommended. I don't like just saying that either one can be done. Thanks.
Yeah, I mean, I think let me just pop in and say that we just were presenting this as, updating ACIP at this point, and just felt we wanted to make ACIP aware of the data, and we're not, we don't have a workroom, we're not bringing forward any recommendations at this time.
Thank you.
Thank you. Dr. Paling?
So thank you for these great presentations. It's wonderful to see the impact that the HPV vaccine has had, and it's very nice to see what is going on around the world. As I'm thinking about this, are we aware of any manufacturers that are going to be submitting a one-dose idea to the FDA? Because I believe we need to have FDA saying one dose is okay before we could even make any movement towards a one dose. Is that correct? And thank you.
I am not aware of any manufacturer that is planning to bring, a one dose data to FDA.
Thank you. And Dr. Kimberlin.
David Kimberlin, AAV Red Book. To follow up with a point that Dr. Daly was making about just the tremendous aspects of this particular virus-like particle vaccine program, do you know of any other vaccine preventable, or maybe not any vaccine preventable diseases yet, but any other diseases for which VLPs are in development?
I am not the best person to answer that question. I wonder if there's anyone from FDA on the call. They might know.
Hi, this is Doran Fink from FDA. So, of course, we are not allowed to disclose non-public information about vaccine developers who may have products under development under IND. However, there are, I think, examples of VLP platform vaccines that have been in the public domain, including, for example, there's a COVID vaccine manufactured by Medicago, a Canadian manufacturer that uses a VLP platform. So that's one example. Over.
Thank you. Are there any additional questions or comments folks would like to make? Dr. Long.
Yeah, this is really, really, really wonderful and interesting all at the same time, and tells us every vaccine and every virus or pathogen is different. But it's interesting that forever pharmaceuticals have focused on immediate antibody responses at 1 month, 2 months, and want to present that. And we think that's kind of the holy grail. And in fact, it's probably not close to it. It's cellular responses. It's how that first exposure alters the immune response and makes for memory cells and makes for continuous stimulation of antibody responses. So in this case, it looks as if the second and the third dose were the spurious levels that didn't really matter. But if one of your graphs you were showing what happened after one dose, it didn't fall down abruptly at all. And it's that if you kind of overstimulate, and then when it's not needed, you can get an antibody response for a short period of time. It could be good for the short run. It could tell you nothing about the long run. So the short-term responses for the coronavirus vaccine seem to be spurious in that they're very high, but they go away very fast. And here, 2 and 3 doses is spurious because they're very high, but they don't mean anything. So I just wish we could get to a little bit more sophisticated and requirements for antibody tests further down the line, not just that 1 month post your last dose of vaccine, and that we could look at the much more sophisticated ways to look at immunization responses that are not dependent on just antibodies. Maybe the FDA could say if they're thinking about any new paradigms of how we look at vaccine responses and what's really the optimal way to look at an adequate versus an inadequate response.
Hi, this is Doran Fink again from FDA. So clearly, with at least certain vaccines, antibodies are not the whole story. To explain the mechanism of protection. Historically, antibodies have been the component of the immune response that is most amenable to evaluation, including for immunobridging analyses that require use of validated assays and high throughput assays to assess large numbers of samples. So clearly there is interest in exploring how other components of the immune response, such as cell-mediated immunity, can be leveraged to inform regulatory decisions and understanding of vaccine effectiveness. And at this point, we're not quite at a place where we can use cell-mediated immune response assays in quite the same way that we've come to rely on antibody-based assays. But to the extent that the field can move forward and develop the assays and the science to get to that place, FDA is happy to be involved in the discussion. Thank you.
Thank you, Dr. Fink. I don't see any additional hands raised. So given the long day and the series of days we've had, I'm going to suggest we adjourn today's ACIP meeting, and we will reconvene again tomorrow, 10 a.m. East Coast time, 7 a.m. West Coast time, and we'll look forward to some additional updates and discussions. So thank you, everybody, for your participation and for the excellent presentations today, and we'll look forward to seeing you again tomorrow.